crashing through when you need someone to carry you. When you're broken on the ground, you will be found. Like the sun comes streaming in, the story shines again. You will be found. You'll be crashing through, running. You will be found. You won't find your way. Have you ever felt nobody was there? Have you ever felt forgotten in the middle of nowhere? Have you ever felt like you could disappear? Like you could fall and no one would hear? Well, let that lonely feeling wash away. Maybe there's a reason to believe you'll be okay. 'Cause when you don't feel strong enough.
Hello. Good morning, distinguished ladies and gentlemen. I'd like to welcome you all to this inaugural event. Thank you all for coming, and we assure you that this morning we will be moving on quite speedily. It is said that it is not enough to be alive. To quickly forget the things that are important. The reason we have any and every society is to better the human life, and nothing is more significant to the human life than the human health. Ladies and gentlemen, I'd like to bid you welcome. And right now, I'd like to do a few recognitions. I'd like to recognize the presence of the representative. This keeps breaking. Can we? Thank you very much. Sounds much better. All right, ladies and gentlemen, shall we please recognize the person of the representative of His Excellency, the Deputy Senate President of the Federal Republic of Nigeria, ably represented by the Chief of Staff, Dr. Otive Ibuzo. Shall we welcome him with a rounding? Doctor, it's fantastic to see you here. Some of us may not know, but he spent extensive time in Action Aid, and then several NGOs promoting the health causes. Good to have you here. At least we are in very good hands. Thank you very much for coming. We also would like to recognize the presence of the Executive Vice Chairman of the Federal Competition and Consumer Protections Commission, Mr. Babatunde Irukera. Shall we welcome him with a resounding round of applause? Thank you very much, sir. Thank you for the work you do at the Human Rights Commission, at the FCCPC. It's longer now, but it encompasses a whole lot more, and some of the work you did in ensuring that the international pharmaceuticals, those big pharmaceuticals that are typically bigger than nations, were able to be held accountable for some of the trials that they did. We thank you very much indeed, sir. The Executive Secretary, the National Human Rights Commission, Mr. Anthony O. Ojukwu, is he here now? Oh no, he's not here. We also would like to recognize the presence of the Chief of Party, IHP, Martha Levitt. Shall we welcome her with a resounding round of applause? I was reading about your organization in India, the NGO that's made up about 100 organizations who are working together to ensure better levels of maternal and mortal delivery, and thank you for the work you do. She's been here in Nigeria for about 4 years now, and she has about approximately 40 years of cognitive experience, on-hand experience, on ground. You see, when we come to conferences, there's a lot of talk, but it's good to have people who are not just talking, but who know exactly what they're doing because they've experienced this thing, they're engaging with the problems and the solutions. And so we thank you very much, Madam, for being here with us. I would also like to recognize the Director, FCT Insurance Secretary, Dr. Ahmed Dan Fulani. Thank you very much, sir. He is someone who believes in private sector efficiency, in public sector delivery, and we thank you for the 24-hour call service thing that you did. It's very good. You never know how difficult it is until you get to a point where you need emergency. There's no number to call. It's too late, and it could be the difference between life or death and quality of life for those who are left living if the person passes on. So thank you, sir. So very much, I would like to move very quickly on this agenda. Shall we all rise for a moment of silence for the people we are gathered here to celebrate? Amen. Shall we be seated, please? Distinguished ladies and gentlemen, without any further ado, I'd like to welcome to the podium to give his remark the representative of the special guest of honor, His Excellency Senator Ovie Omo-Agege, the Deputy Senate President, ably represented here by his Chief of Staff. Shall we welcome him with a resounding round of applause as he gives the remark?
Distinguished guests, ladies and gentlemen, I bring greetings from the Deputy President of the Senate, His Excellency Senator Ovie Omo-Agege, who would have loved to be here, but because of other national assignments, and he has asked me to represent him. I will just read his brief speech. It gives me great pleasure to be here today to be part of the inaugural Francis and Felicia Memorial Lecture and Roundtable discussions. I am convinced that today's event, apart from bringing us together, should create awareness about healthcare and also make it possible for mutual exchange of ideas on improving access to quality healthcare. The place of healthcare cannot be overemphasized in any successful economy, especially in terms of contribution to human capital development. Hence, the popular maxim, health is wealth. I'm sure that is why the theme of the inaugural lecture is the people's right to quality healthcare, which I find to be most appropriate. I also find the captioning of the sub-theme, improving access to quality healthcare, interesting. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic or social condition. Over 70 years after these words were adopted in the Constitution of the World Health Organization, today they are more powerful and relevant than ever. Since day one, the right to health has been central to the federal government's identity and mandate. It is at the heart of our priority, universal health coverage. The right to health for all people means that everyone should have access to the health services they need, when and where they need them, without suffering financial hardship. No one should get sick and die just because they are poor or because they cannot access the health services they need. Good health is also clearly determined by other basic human rights, including access to safe drinking water and sanitation, nutritious foods, adequate housing, education, and safe working conditions. The right to health also means that everyone should be entitled to control their own health and body, including having access to sexual and reproductive information and services, free from violence and discrimination. Ladies and gentlemen, in Nigeria, the national health policy represents the collective will of the governments and people of this country to provide a comprehensive healthcare system that is based on primary healthcare. It describes the goals, structure, strategy, and policy direction of the healthcare delivery system in Nigeria. The National Assembly works with the National Health Policy Implementation, Monitoring, and Evaluation Policy Objective. The overall policy objective is to strengthen the national health system such that it will provide effective, efficient, quality, accessible, and affordable health services that will improve the health status of Nigerians through proper oversight and legislations. However, it is good to be aware that we still have a long way to go until everyone, no matter who they are, where they live, or how much money they have, has access to these basic human rights, the right to health. Once again, let me use this opportunity to thank all the partners for their collaborations as we look forward to more collaboration on these and other initiatives. I wish you all happy deliberations. Thank you very much, and God bless.
Thank you very much, sir. Hello. Thank you very much, sir. We appreciate that address. For, as some of us may know, the Deputy Senate President, they are engaged in the very difficult and pressing matter of the constitutional review, and to have the presence of mind to send his Chief of Staff is something that we appreciate and shows that you take health quite seriously. Thank you. And moving on, because of time, we're going to skip a bit and go straight to the keynote presentation. Distinguished ladies and gentlemen, shall we welcome to the podium the Federal Competition's Consumer Protections Commission's Chief Executive Officer and Executive Vice Chairman. Shall we welcome with a resounding round of applause Babatunde Irokere for his presentation.
Good morning, ladies and gentlemen. Please permit me to stand on the already well established protocols. And first like to start by appreciating the kind invitation of the Francis and Felicia Umenyi Foundation to participate in this memorial lecture. I didn't have the privilege of knowing Mr. Umenyi, but in my early days of returning to Nigeria, I worked quite closely with Mrs. Umenyi at the then CPC. Little did I know that fate was going to run a circle and bring me to ultimately work in the same organization that she worked at the time. The one thing that I came away with in my interactions with her is an incredible amount of energy and a very positive spirit and undying, unapologetic approach to protecting people. And so I am not surprised at all that I find her children in a similar space, doing the things that really should be of the most value. At the end of the day, the question that I think we would answer for ourselves as individuals, when all is counted and done, is not going to be the difference in how much we made, but the difference in how much difference we made. And so today, to speak about something nearly as topical as healthcare in an environment where in reality the gaps are gaping, the sense of urgency stares us in the face, and most sadly, the losses are irreparable. That demonstrates to me that you have a team of people who have prioritized what matters the most. And it's a place where you would certainly succeed. Because if what your effort does is to save one life, you have succeeded far more than many other initiatives that would transcend the entire globe in our lifetime. And I must say, one of the saddest things for me, both as a lawyer and even as a regulator now, is what the real indices about our healthcare is in Nigeria. Failing infrastructure, both from a hard infrastructure standpoint and a soft infrastructure standpoint. The limited recognition for the value of life. The undisputed sense of indifference. And most of all, the mindless, needless losses of life every day. We have absolutely no control over whether people will die or not. Perhaps we don't have that much control over whether people will fall sick or not. But I have absolutely no questions in my mind, and I'm not deluded about the fact that the sheer number of people who die needlessly, we have control over. And efforts like this bring to bear how to exercise that control. When I assumed the role of the then Director General of the Consumer Protection Council in April 2017, the first thing I set out to do, the very first thing, the first project I started within days of assuming the role, was to start on the work that ultimately became the Patient's Bill of Rights. It's a very small contribution to address what really is the soft infrastructure to improve healthcare. And to find that a team of people look at that and find in it a platform to even start and begin to move forward tells me that there is hope. Prior to when we had the Patient's Bill of Rights, the record at the Consumer Protection Council was that in the 4 years prior to that, not one complaint against a healthcare facility existed. From the launch of the Patient's Bill of Rights, on the last day of July 2018 to December 2018, we had over 20 complaints, meaning that the lack of complaints was not an expression of how well things were. It was just a lack of knowledge and process for dissatisfaction to be expressed. And so for you to stand on that platform, you're making history. And to identify the key issue there, which ultimately encompasses and encapsulates the totality of what the value chain is, which is quality of care. because it transcends everything. To break it down to a further sub-theme, to say quality from what standpoint? Both the soft standpoint, which is access. Access from an affordability standpoint, from a framework standpoint, and then access even from a physical standpoint. Because if we can address the access question, we will certainly succeed in saving lives. And so I think that in honoring your parents, you have done what nations should do. And so for that, you have made history. And because I am confident that the situation is so bad and your work will contribute, not only would you have made history, because you would save at least one life and prevent one death at a minimum, you are enhancing an enduring legacy for your parents and even for yourselves. Because the people who die the most in any country, more so in a developing country like Nigeria, are the most vulnerable. Our dismal, abysmal, sadly very shameful record of infant or maternal mortality alone for a country the size of Nigeria, with the wealth of Nigeria, with the training available in the Nigeria, with the expertise that is in this country. There's absolutely no combination of factors that can excuse or explain why we belong at the bottom of the pile with respect to infant and maternal mortality. And I dare say that the crux of that is quality. Quality from an access standpoint, from a framework standpoint, and most of all, from a physical facility standpoint. And you know, moving the needle doesn't require moving the entire nation. And that's where I find the work that you've set out to do very interesting. That you've narrowed it down to small pieces. And let's do the small things. Let's do the small things, save some lives while waiting for the big things to happen. Because if we succeed in doing the small things and we save a life or the other, we have absolutely no idea what that life we've saved is. And I'm going to close by two experiences that I have heard. One, more recent. In 2006, I was driving in a car from Abuja to Kano. And the driver and the gentleman who were taking us on this trip stopped to buy suya to entertain the gentleman and I who were seated in the back of the seat in the car. And so they bought suya. I think I was bored with the trip. So I started reading the news on the old newspaper the suya was sold in. It was a difficult read because it was really oily. But what I was reading was a serialized report in Daily Trust. It's something that was initially published by the Washington Times about a clinical trial that had gone bad in Kano, approximately a decade to that report. And as I read it, when we got to Kaduna on the way to Kano, I said, I must buy the entire Daily Trust for the past 2 days. The only place to buy old newspapers, some of you might know, is usually the library. You can find it with the vendors. We made a detour to get the old newspapers, and I read everything. And from there we built a theory of harm, a theory of liability, to hold the then largest pharmaceutical company in the world to account, to resolve what was really an opportunistic endeavor, because they wanted to test a medication that eventually was not even going to be affordable in Nigeria anyway. The last I checked, about 4 years ago, I understand that that accountability framework that we created, that holding that company down to account, it cost them $80-something million in settlement, including the largest infectious disease hospital in Nigeria, currently sited in Kano, has reduced clinical trials in Africa by up to 50%. So that's how your little contribution, no matter what it is, can contribute to a larger value chain. And the last one I would end with are two. One is an experience in the United States with an older couple, family friend, a blended family, and they decided to have a child. Both of them had children from their previous marriages, and in between them they had 7 children. That's a pretty large family. And so their attempt at this one child resulted in a child that had some congenital problems at birth. I was new in the United States at the time. I was just trying to qualify as a lawyer. But I'd never seen such a struggle in the Cook County Hospital, which is a public hospital, by the way, to save the life of a child. And even when the parents had quit, the doctors didn't quit. They put every possible resource into saving the life of that child. And so when we were settling this pharmaceutical case, and a respected person in this country, acting on behalf of the pharmaceutical company, was advocating for a walkaway. And I said in a meeting that, sir, there is nothing that is offered that's not a lot of money. $30 million on the table anywhere in the world is a lot of money. But so that's not the value. What we insist on is that the life of a child in Kano is no different from the life of a child in Manhattan. And by the way, the life of a child in Manhattan, from a legal standpoint, is not even worth much. The way to calculate injury and damages is to look at lost income or possibility of additional income. And children don't make any income. But there's a value, and that's why they fight for the life of each child. I was very saddened that a very respected and senior person in this country didn't share that view and felt the chances of a child in Manhattan is different from the chances of a child in Kano. I said, well, chances may be different, but the value of that life is the same. We must go back to valuing life. And that's what quality of care does. The most contentious headbutts that I have had in my work at the FCCPC is fighting in the medical space. My sister is a doctor, and I say to her, the most tragic commentary of the medical profession is that somehow we've gotten to a place where collective bargaining can result in strikes. For every other profession, for every other thing, there is no loss on account of a strike that is unrecoverable. But the cost of strikes in medicine is ultimate, because people die. And I do not begrudge medical doctors for their displeasure or dissatisfaction with a failing governance system, whether it's from an infrastructure or remuneration standpoint. A system that has failed so much that we export doctors like we export oil. But then, I still will never reconcile the cost we pay to ventilate that aggravation or dissatisfaction with the reality of the outcomes. And so here we are. I enjoin you that as we go into these conversations about quality of care, we recognize that this is not an event. There's an urgency. There is an urgency that we must focus on. And it's easy to give up and say, well, what can we, a small group, do? But like I started, if we save one life, we've succeeded. I wish you the very best. I congratulate you on this effort. And I have absolutely no question that it's one of those efforts that succeeds even right from the beginning. Thank you and good morning.
Thank you very much, sir. Could you just give us a minute of your time? Shall we welcome straight to the microphone the Executive Director, Francis and Felicia Umenyi Foundation, Dr. Chito Nwanna. She has a few things to say before we proceed.
Permit me to stand on all existing protocols. Good morning, distinguished guests. We are very happy that I'm just happy to see the room because we have really speakers and we have visitors here that are guests here that are well, that are vast in the knowledge of what we're discussing today. I just wanted to give a little brief background before we quickly invite our next speaker, Dr. Martha Levitt. The reason for this gathering, how it came about, I want to first tell you, it came to honor our parents. My father was a public health advocate, and in his time, one of the greatest concerns for him then was access to health care. And it's funny that years later, he died 20 years ago, we're still talking about the same problem. But his was focused on patients diagnosed with leprosy and their marginalization. My mother, Mrs. Ife Umenyi, was someone who served humanity by protecting the rights of consumers. So for those that don't know, she was actually a former DG of Consumer Protection Council that is now known as the FCCPC. It was then known as CPC. So this topic was just the best topic you can think of, because many times when people think of the Patient Bill of Rights, they think of it more, I talk to my colleagues, people talk about it more, or my friends talk about it more as when you go to a hospital, you're not treated properly, your right to quality care, but we forget something else, the other side of it. I feel personally the most important side of it is for those that don't even have health care. Those that actually, it's not about how good the care is, they just don't have it. And that's why this topic is so important in our time. And even if you're here and you're not in the health sector, it's still important to you because you do access healthcare for your needs. So this whole forum is really for solutions. We know the problem. Most of us in the field have hashed out the problems over and over and over again. But this time we want to create a blueprint. As we speak, we're writing our communique, we're writing our blueprints, we're writing our roadmap, because we want a solution or solutions to come out of this meeting. And to do that, that's why we have people that are in the field, people that have done a lot of work. We have people from both the government, the legislature, we have IHP with us, we have FC with us, we have World Health with us. So we know that we are in the right place to get solutions, and I pray that that's what we accomplish in this meeting. The goal of FFUF, Francis Felicia Umenyi Foundation, is to be part of that narrative, to fulfill the dreams of our parents, to fulfill our dreams that everybody has right to health care, and we will be the voice of the voiceless as we continue to work towards achieving that. Thank you all for being here. God bless.
Thank you very much, Dr. Chito. I think if nothing else, Francis and Felicia Umenyi Foundation have proven something that Nigerians don't believe. They've turned it on its head. We don't believe that one person can make a difference. And we are gathered here simply because two individuals, individually and collectively, made a strong difference in the areas that they worked in healthcare. And even though they are no longer physically with us, that dream, that ideology, that passion that they pursued has grown and continues to abide with us, and is the reason for which we are gathered. I'd like to welcome immediately to the microphone Martha Levitt, PhD from...
First of all, it is an absolute honor to be asked to participate with this austere audience, and can I please be on protocols that were so beautifully done already? I couldn't possibly do it justice. But thank you so much. I think I have a presentation you're trying to, okay. So in the meantime, let me just tell you, I represent the USAID Integrated Health Program. We are a contractor for USAID Nigeria, and we are the flagship service delivery project. And we work in, the next slide maybe, we work in 5 states. We work in Bauchi, Kebbi, Sokoto, Ebonyi, and right here in FCT. And you know, these states have probably some of the worst health indicators that we've seen. I mean, FCT is better, but there are still huge pockets of FCT that where you have very much underserved people. And so this is where we work, and we are covering almost about 11.9 million women and children, a population that doesn't mean they're served. We work through the government, we work through the primary health care system, and so we've heard a lot about maybe the higher level, but I'm going to take you to the ward level, because we work at the ward level where the people are most vulnerable and they don't necessarily have access to basic health care. And the only way you're going to turn your indicators around in Nigeria is that if each person has access to preventive, promotive, diagnostic, and curative care. They need the whole continuum. And unfortunately in Nigeria, many people are dying of preventable diseases, children dying of preventable diseases. For me, is heartbreaking. Any one child that dies of malaria, or they die of polio, or they get polio. We still have some wild polio in Nigeria. It's one of the last strongholds, but although Nigeria's done very well, it still has some. Please. So I've been here for 4 years, and I came to Nigeria because and this will be my last big career move. I'm retiring after this, I think after 40-something years. But I feel that Nigeria, if they just move a little, we will see an incredible change. We'll be saving so many mothers and children, and when Nigeria succeeds, the world succeeds. And I will say that I've been here and I'm so impressed with the Nigerians. Your human resources are incredible. No excuses. I heard that. It's true. There are no excuses. Brilliant people, committed people, but there are things that stand in the way. Poverty is one of them, and just the flow of funding for health. Health does not really seem to be a priority when you look at budgets of the states, honestly. So anyway, we're here to save the lives of mothers and children. Please, next. And we work to improve the systems and the services, access to services and quality of services. Next. And we work in many areas because you can't just work. This is an integrated health program. We can't just do one thing. So we do all the health system strengthening, maternal health, newborn health, child health, adolescent health, family planning, nutrition, and malaria. And that's what the primary health care development system is. If you look at the Primary Health Care Under One Roof Act, that's what it's about. A person can walk through the door of a primary health care center and get whatever they need. A child will get a full array of services. They'll get immunized. If they have a fever, they'll be tested for malaria. And if they don't have malaria, and they'll be treated. And if they don't have malaria, we find out what else. So it has to be holistic. Anyone who walks through these, little primary health care development centers. And I just want to say that about 80% or 70% of all health care is going to happen there. So we all have our HMOs and we all have our insurance and we go to these very lovely places, but most of the people in Nigeria don't have that kind of access. So we'll talk about that in a minute, what they do have access to. Next. So we are here to strengthen existing systems, both public and private. We're not here to start new systems, but we do want to help. And I will tell you, I have over 250 staff, and I'm the only American. It's all Nigerians, okay? So the kinds of committed people that I work with, public health professionals, health finance experts, you name it, we have it, and they're all incredibly dedicated to making this program work. So we focus on addressing supply side barriers that happen at the facility. Why don't people come to the facility for service? There are many reasons. One, it might be too far. Number two, women may not be allowed to go by themselves. They need an accompaniment. And so, thank you. Okay, so our big activity is we really are building capacity of these people who work at the grassroots. These are your frontline workers. They are out there every day in the wards, in the settlements, trying to provide health care. So we are building at the state level, at the local government, in the primary health care centers, and at the ward. Thank you. Next. So I do want to talk a little bit. We're going to talk about the Basic Health Care Provision Fund and the state health insurance schemes. These are two ways that we can start in Nigeria to achieve universal health coverage. The poorest of the poor, not even the poorest of the poor, you don't even have to be poor. One medical problem can put any family into poverty, right? You'll do anything to protect your family. If somebody gets sick, they get cancer, whatever it might be, they're delivering a baby and they have a crisis, we will sell our land, we'll sell our jewelry, we'll do whatever it takes, right? So can you imagine people who have nothing, they live on so little every day, and they are also experiencing this at even a higher rate. So how do we help? The government has come up with a couple of schemes. The Basic Health Care Provision Fund addresses the poorest of the poor and provides the premiums for their health insurance. So they get a package of service that they can get, and they don't have to pay for the services because they're enrolled and they have a card. Now the state health insurance scheme is a little bit different. That you have to pay the premiums. So I don't know who are the people here in this audience, but there is something called Adopt a Family, and I really want to promote it. If you want to help the poorest of the poor, you can actually put funding into the equity fund of the state health insurance scheme, and you can pay for the premiums of some people that you really feel are vulnerable and need help. So that's something to think about. Okay, so what do? We do clinical skill development next. And you can see some more training that we do. All of our training is at the facility, in the primary health care centers, in the general hospitals. Nothing is like you bring people to a hotel and you try to train them. No, it's at the facility. Next. And these are packaged. We have what we call, these are low-dose, high-frequency modules for different topics, and they are brought with the equipment to the facility. Next. Because it's very important. We don't want people to have access to bad health care. We want them to have access to good health care. So that's why we spend so much time. And these are just some ways that we do the low-dose, high-frequency. It's hands-on, it's on-site. Next. So integrated health is very important. Any child, any woman, any man, they should be able to get a range of services. All children who come in should get immunized. Make sure they're fully immunized. And then we should make sure if they're sick, they get treated appropriately. Next. We work on gender, and that's very important because many women don't have the authority, they don't even have the money to access health care. They depend on their family. And so we have found men to be very interested. They say, we want to understand, we want to know about pregnancy, we want to understand the care, we want to know about delivery and the care of the newborn. And I've seen a revolution in my time of men's role in the family. totally different from when I was growing up. My father would go to work, he'd come home late at night, have his dinner, I would say hello to him, good night, and that was the end. I don't think I had a whole conversation with my father my whole life. I mean, when I was young. So things have changed. Men are really stepping up. They're really taking active role as fathers, as husbands, and I really would love, to see that more and more. So I see a lot of Nigerian men stepping up, and they want to know more. So we're bringing them in. We're making sure that they are part of it. Thank you. We're also using, as much as we can, digital health solutions. We have a mobile curricula. We have audio job aids. So Airtel is a partner, and any health worker could call 321 and access a mobile library of information. And then we have a hotline. Any client can call the hotline and say, the healthcare worker wasn't there. There were no commodities. This is a problem. Or they could say, I had a good experience. Next. Okay, and we're working with the private sector is important. You cannot ignore the private sector. People go to the private sector, whether it is a health facility or the PPMVs and community pharmacists. People go there. We have to work with them, and we are working with them. Next. This is my baby. I am passionate about this. How can primary health care centers not have electricity? 50% have no electricity. You go and you do a delivery, they have a flashlight or a lantern or something. I mean, this is not right, and it's not safe. What health worker wants to work at night with no lights on? So I'm very passionate about this, and we're working with the Rural Electric Authority, the National Primary Health Care Center, and a lot of private sector, and also the USAID Power Africa initiative to try to get electricity to these health facilities in the rural areas. Thank you. Sustainability is critical. You can do all the wonderful work, and then tomorrow you leave and the whole thing collapses. So we are helping the states to look at how sustainable are their programs. Next. Okay, next. So capacity building is the basis of our work. To empower health workers, to empower health managers and decision makers and people who look at data and collect data. Please, next. And we use a variety of training approaches. This is using an anatomical model. It's a humanistic approach. You don't want to practice at first on a person, right? I don't want anybody practicing me with that. So first you get competent on an anatomical model, and we put them in every single facility so they can continue to practice. And then once they get competent on the anatomical model, then they can start working with a coach on clients. Next. Okay, what's happening? What are the results? We are very results-oriented. If we're not achieving improved health, I don't know what we're doing here. We're not just here to train people and have workshops in hotels, etc. Please, next. So, where are we? So we're beginning to see the fruits of our labor. We're beginning to see that deliveries in a health facility are going up. We're seeing that deliveries by a skilled birth attendant facilities is going up. We're seeing that, let's see, you can't really see that blue one up here, but also the use of a partograph monitoring tool for delivery is going up. Thank you. And here's child's health. When we started, the child health treatment and diagnosis was terrible. Even if a child had diarrhea, they didn't get ORS and zinc. And if they had pneumonia, they didn't get antibiotics. So we are really seeing an improvement. Almost 100% of those diagnosed are now getting treated. So I'm really proud of that. Next. Thank you. Next. Okay, here's malaria. Now we know malaria is the #1 killer in Nigeria. There is no doubt about it. Child mortality, maternal mortality, almost a very high percent. So when we started, it was not every person who came in for a fever was treated, but now you can see over 90% of people who come in with a fever get tested. Now, you don't just treat people if they're not positive. You're wasting your valuable drugs. So, and also you're causing resistance to drugs. So you test. If they're positive, we treat on the spot. And this is very, very important. And no treatment without testing. That's our mantra. Next. Next. So we're trying some interesting ways to increase, scale up, reach people. We are trying to reach the whole states that we work in. PHC revitalization. Adopt a PHC. Here's another way that you can contribute as an individual or as a family or as a foundation. Select a PHC or in an area you care about and help revitalize it. Don't wait for the government. The government can do what it can. It has very little reserves of funding. Go in, paint the place, fix the roof, make sure there's water connected. If you could put electricity, connect with electricity, please. We need every single Nigerian to take an effort. A little effort goes a long way. Next. So here are some of our innovative models now. Because not everyone comes to our facility, we're taking the facility to the people. Because otherwise we're not serving. And then so many children are dying of malaria because the family, only 33% bring their sick child to a facility. So some people, I just heard today, well, if you just go out to them, they'll never come to a facility. Who cares? We're here to save lives. No, if they can't come to the facility, it's too far, they don't have money for transport, we need to go out to them. The government needs to reach out to them. So we're doing that, and we also have something called the Open Maternity Day. Now, this is an interesting concept. My daughter was pregnant, and we went to the facility where she was going to deliver and got a tour. And then we went there and we said, you know, we don't really like this facility. Let's look for another one. So then we went to another one where we really thought this is going to be better. So we did this tour. And I said, why don't we do that? Because people have never even gone to their facilities. They don't know what it's like. They don't know the health workers. They don't know what services. So it's called Open Maternity Day, and it's a big hit. Hundreds of women and their husbands are coming to these facilities to learn about the services and even to get services while they're here. So I'm really excited about it. It was just like, I don't know, it just kind of came to me. We're also doing PHC, what I'm calling PHC extension services, because you're literally taking the primary health care center and bringing it closer to the people. So you can see the services that are, all the services you get in a PHC you can get there, except for delivery and maybe an IUD insertion, because that would be difficult. But you're really bringing all the services. Next. And here's just some of the work we've been doing for the last 4 years, and I thank you for your attention, but bringing quality services to vulnerable populations and making a difference is what we are about, and we hope that we're able to move that needle better and better over time. Thank you so much.
Thank you very much. Please, another resounding round of applause there. I think one thing we can see very clearly from Matalevi's presentation is that she cares for the people that she works for. When you're talking about giving them the tour of the facility so the people, they get to know the place, and that goes a long way in the patient's confidence and his or her willingness to confide in the health worker and tell what the real issue is. We thank you very much. Now, some may be asking, what is the Francis and Felicia Umenyi Foundation? What do they do? Why should I care? If that is you, if you're asking those questions, we have an answer for you. A video presentation. Thank you.
one of the things that really gets to me sometimes is when we go for the outreach and we meet mothers, and then we asking them, we normally ask this question, how many pregnancies have you had? And they will tell me, okay, I've had 6. Okay, how many children do you have? And so we have 3. Oh, did you have 3 miscarriages? And they're like, no, first I had 6 of them, but out of them 2 has died. And they say to her straight face. I remember the first time I heard her, I looked at her and she just said, died? She had diarrhea. Look, I looked at her and there was no emotions in her face. And she said, yes, they were sick, and this one was sick, and this one had diarrhea. But I have 3 remaining. And I for her, obviously, a mother's defense mechanism. One child died is heartbreaking. And for her, obviously, what you're seeing is a defense mechanism. So I just looked at her saying to herself, any of these kids could die, and most of us have to survive because of lack of access. So I just looked at her and I knew she was just a survivor. Most of these kids died because of lack of access to quality health care. And that truly breaks my heart. Francis Felicia Umenyi Foundation basically was created because of, in memory of our parents, my mom and my dad. They were selfless human beings, and we grew up, watching them, always reaching out or giving out or being nice to everyone. And then I just always remembered, even as of recent, because my mom is more recent, always thinks about others before herself. And it was something that we grew into. And I remember when the outreach started, she was still alive anyways. And she was so excited about it. She was part of it. She would be like all up in it, So I know that when she passed, that was the first thing we could think of that we will do to keep her legacy going. And one thing that we know is that it's something she did even in her hometown, in the village. Whenever she's around, they gather. So this was like, we just need to give back just the way my mom and dad did.
We come with a team of about, say, 40 volunteers. This include the medical team with nurses, medical lab scientists. We have the medical doctors, consultants or specialists such as the pediatrician, the obstetrician and gynecologist. We also have other team volunteers for logistics and all. We see an average of about 500 to 800 people a day, with children, inclusive of children. For malaria tests, we can say we test about 200, let's say 200 an average. And then blood sugar, mostly adults, and those especially in a certain age, say from 30, 35 and above. So those are the age groups that we do some tests such as the blood sugar. And of course, those who haven't had their status checked, such as the HIV and hepatitis B, we also try to check them. So most adults have, with their consent, have us check them. We also give medications such as anti-malarias, deworming for the kids, for children less than 2 years old, and those up to about say 12 we do, or those who adults haven't dewormed themselves, we also deworm them. So we need enough anti-deworming medications, we need enough anti-malaria meds, we need multivitamins for the children, and paracetamol or analgesics for those who need them.
My name is Obiefina Mary Rose Ukwoma. I'm from Oga in Agata local government area, Anambra State. In the year 2016, I experienced a chest tightening with severe pains after my first childbirth. In the year 2018, I gave birth to my second child. I experienced such pains again with severe pains. It was like a hell. The pains was so severe. We went to several hospitals. After much more, I was diagnosed with a gallstone bladder. The doctor told my parents that the best treatment for gallstone is a surgery, which we went to one hospital in Port Harcourt. They booked us for a surgery. They said they're going to pay 1 million naira for the surgery to be done. There was no money, we couldn't further with the surgery then. We went to teaching hospital. The doctor there now recommended us to go to India for the surgery. There was no money to do all these things, But I thank God that with the help of Francis and Felicia Umenyi's Foundation, I'm alive today. I'm a living testimony. What God did in my life was a marvelous thing.
I was volunteering in the eye care section of the outreach because we had the surgery, we had dental, we had counseling, faith counseling, we had eye care. There were like almost 3 or 4 different things going on at the same time in terms of healthcare. So I was at the eye care that day because this was like a 5-day outreach. I was in the healthcare that day, and one lady came after doing her test and getting reading glasses and using the glasses, and she said, "So I haven't been seeing all this time. I never knew that I couldn't see. I never knew I could not see. I see everything so clearly. So this is me. So this is my village. So this, and she was just praising God. She was so thankful that she was able to see clearly before she died. And she was a bit elderly, but not that elderly.
First outreach we did was in Umenyi. It's a village we adopted, the Francis and Felicia Umenyi Foundation adopted. So where we went there, and then we did a 1-day medical outreach, and we catered to like hundreds of women and men and children.
Initially when you start the outreach, the first one especially, I think that's just the first. The first one, you're like, okay, let's do this, and you get there. But when you see the impact of what your little, whatever you have, does to them, the impact that it has on the children, on the mothers, and all of them, trust me, it becomes, like for me, and the outreach is part of me. It's part of my everyday life. I remember when we did door-to-door. We did the door-to-door in Umenyi, and they would run out and we're saying, we're coming to you. This time around, we wanted to go and drop it at the doors, like everybody's door. We will get to you, and they will just be looking at you as you're walking to their section to make sure that you don't miss them. And then I'll just say, go right back to your door. And once you drop it, oh my God, it's as if you've dropped so much and all that. I think to me, whichever way, I think to me that has been the best, going into their house. That's door to door. In fact, it made me even see how people live, because you don't know how they live door to door, face to face, all those things they talk about. You see it live, and then you see how happy they are with that little stuff you dropped in front of them. It will go a long way to feed their families.
Part of our work is trying to improve access to healthcare. That is a major problem. You can have quality healthcare. If people can't even access quality healthcare, it's like it doesn't exist. People will suffer, people will die. And one of the major part of care is what we call preventive care. caring for kids, making sure they're eating right, making sure they're well immunized, making sure that they're growing properly, caring for women and whether pregnant, non-pregnant, and making sure that we identify any ailment that we could treat early. These are all very important parts of care, preventive care, which can be done at any primary health center. Remember when I said that sometimes when people have to go they deal with severe illness, they have to go to the nearest referral hospital. It's like almost sometimes can take 1,000 naira to go and come back from that location. Now we're dealing with homes, right? We're dealing with homes where their average income could be like maybe 10,000 naira a month. And if you net out maybe their transportation to work or other things, it could even be less. And you're dealing with that. 1,000 is a huge percentage of that money. And they have kids and they have other kids. So sometimes they do choose to feed, which, I mean, you can't really blame them. No parent wants to watch their child crying and hunger. And I think that's one of the worst things to watch. So this is one of a big challenge we have, and why it's important that, yes, we have referral hospital, but we should never be opposed to increasing the standard of care seen in primary health care centers. They are primary health care, but there's primary health care in other specialties too. And being able to engage specialists and providers that are maybe more trained in certain areas is not going to be a bad thing for the primary healthcare centers. So I think that's something that we should look at, is bringing healthcare to their doorsteps, as close to the doorsteps as we can. Pretty much by collaboration and partnerships. And we are still working on it. One of the things that we're working on now is that we've decided that just this may not work, we will not serve the community as well as we want to. So right now what we're doing is we're actually adopting communities one at a time, so that we're able to go back to the same place and serve them. We decided to take it one step further when we realized that every time we drive out of the community, children and women are running after the car because, I mean, just can't serve everybody. We have now at least signed an MOU with the FCT Primary Healthcare Board to try a new template of actually adopting a primary health center or working with them to be able to offer better quality or higher specialized care close to their doors. And we're just in the process of getting approval from AMAC, and in partnership with Tabitha Medical Center. So hopefully it'll be a template that works. And if it works there, we'll now move to other places and hopefully engage other, like my colleagues are here from the private health sector. So hopefully we'll start doing that in a broader sense. And we believe that it will definitely make an impact. So we're open for collaborations, we're open for partnerships. We can't do this alone. We have to hold hands with each other and get the work done so that the voiceless will have a place. Thank you.
All right, distinguished ladies and gentlemen, thank you very much. We will be moving to the panel session right now, and just give the team a few more seconds or so to get the stage set so we can invite our panelists to the stage. Please remember that people are going to walk. Can you move this here a little bit to give? Distinguished ladies and gentlemen, Ladies and gentlemen, to move on to the panelist session, I would like to introduce the moderator for this particular session. She is a communicator par excellence, a mentor, an administrator, a public figure, an embodiment of the movement of transformation through excellence and commitment. Distinguished ladies and gentlemen, shall we please put our hands together and welcome the moderator of this particular session. She is Dayo Benjamin's Lani, the Executive Managing Director, Doxa Digital, and our personal mentor. Good to have you, Ma.
And it's always great to celebrate a distinctive mentee. Please help me appreciate Reward. Reward has been outstanding. So please do help me put your hands together and appreciate him, our MC. I'd like to welcome everyone to what today is clearly a celebration of a very distinctive DNA family legacy of Francis and Ife Umenyi. Train up a child in the way they should go, and when they are old, they shall not depart from it. What we train the next generation with will produce not just advocacy, but indeed true legacy. I welcome all of us to this moment of legacy, and I sit here privileged to be one of the distinctive mentees of Mommy Felicia Umenyi, a woman who impacted not just her profession and her space in the place of institutional representations in Nigeria, but impacted people like me watching her, because we discovered through her commitment and professionalism that excellence is never by chance, it is by choice. It is deliberate, it is intentional, and it produces the dividends in due course that produce value chains in government, in entrepreneurship, but most importantly, the institutional of personal purpose. My name is Dayo Benjamin Lani, and I'd like to thank the foundation for giving me this unique celebration of these lives, these personalities, by calling up this next distinctive representation, supermodels in their own spaces of public and private representation, and their interventions when it comes to the subject matter of changing lives through the lives they have distinctively become through their professions and their own expressions. She's the founder of White Ribbon Alliance for Safe Motherhood in Africa. I'm looking around for her. For Safe Motherhood in India, a coalition of over 100 organizations focused on reducing maternal and newborn deaths in India. She has about 40 years of on-the-field working experience dealing with the issues of maternal and newborn deaths. She has spent the last 4 years in Nigeria as chief of the USAID program focused on reducing morbidity and mortality of women and children. Ladies and gentlemen, please let's make welcome the Chief of Party Integrated Health Program, Martha Levitt, PhD. Earlier on, she came up. I'm sure that maybe she's somewhere around getting something sorted out. I would very. Oh dear. Okay, then I'd like to very properly excuse her absence. We've already heard her presentation, and I will be taking interventions from that. He's a recipient of several impressive meritorious service awards for excellence in both public and private sectors, amongst them the Best Medical Director of all FCT hospitals, a mark of distinction of excellence for those who have rendered transformative leadership to the benefit of the Federal Capital Territory and the nation at large. Dr. Mohammed Ahmed Damfulani. Damfulani, please let's welcome him. Please celebrate him as he comes up. Celebrate him. A strong believer of private sector efficiency in public sector, an innovator with accomplishments, and the founder of Air Aid Africa Foundation, director of FCT Health Insurance Scheme. Sir, what a pleasure to have you on this platform this morning. Another round of applause for him. Thank you. I would now like to invite health advocate, physician, and on-the-field operator, Dr. Uchenna, community health physician and senior malaria technical advisor at the WHO. Please let's welcome and receive him upstage. Dr. Uchenna, morning, and welcome. I'd also like to invite, please come up, a human rights activist, committed human rights defender with over 35 years of legal professional experience. He championed the fight against sexual and gender-based violence, of which was the first to institute government quasi-judicial panels of investigation on SGBV to bring accountability to bear for violence against women. He has a very distinguished career in public service in different spheres. Please welcome Executive Secretary, Mr. Anthony Okechukwu Ochukwu, Esquire. Please, a round of applause. Let's celebrate and welcome him. Dr. Haruna Daniel. Dr. Haruna Daniel, health is one of the problems of policy development is that policy is often created with little input from those on the field with and managing various issues arising. Happily today, we have the privilege of the experience of one of Nigeria's and FCT's most adapted in the field. Please make welcome Acting State Coordinator, World Health Organization, FCT Office, Dr. Haruna Daniel. Thank you very much. Please keep celebrating and welcome him upstage. And to be seated here with me is someone who in the genealogy of what I do and what Reward does, now gives me the pleasure of introducing a mentor for me. She's a foremost broadcaster with a distinguished record of excellence, productivity, and distinctive reporting style, a health champion across the West African sub-region, a global voice who has served even in capacity with her husband's diplomatic representations across the world for physical and mental well-being of mankind and all of the representations as a communicator, entrepreneur, media mastermind, executive director, International Society for Media, Mrs. Moji Makojona. Please let us welcome, thank you very much, my auntie. Bless you, bye. And I should state she's also a national award. Distinguished NFR. Please, let us put our hands together and properly celebrate her. Mrs. Mojima Kojuola, NFR. Well, today the subject matter speaks for itself. We're speaking about the legacy of health, not as a privilege, but as a right. And by the representation, not of a global standards organization, but what is our own humanity in the intervention, whether it's in the place of professional public sector representation, private sector, or personal advocacy. We've all heard it today. Adopt a PHC simply means find a primary health care center that you will give your impetus, your influence, and your intervention to. Spotlighting all of this, we have heard. I'm going to take very quickly from Auntie Mojima Kojuola, her own interventions. She's been in this space as a media, carbon foot everywhere, everywhere already. You've been there. You know what it is right there. Right there. What's the architecture, the reality now, and the conversation shall continue from there. And we're looking at solutions. What is a solution orientation from a media representation overview? Thank you, ma'am.
Thank you very much, Dio. Ladies and gentlemen, it's emotional for me to sit here, considering that I lost my mother to neglect at the hospital on the 14th of February when the world was celebrating love. I was also celebrating, should I say celebrate? Or we were mourning because of neglect at the hospital. I lost my 32-year-old cousin to a road accident. He didn't die on the spot. He was moved from 2 hospitals in Lagos to the 3rd where he eventually breathed his last. So in putting all this together, in a place where we say we're lucky to be urbanized, and you get such neglect and such huge loss. My mom died at 49, and I lost this last one at 32. So it's instructive for me to be here today and to share with you that we have a huge problem. We might not know the magnitude of the problem, maybe because you are not so affected. But I know for Chito and the family, it comes alive. So thank you for inviting me here to share with you what we see. And I'm sure the medical practitioners here would speak to the fact. I'm going to speak on two things: equity, health promotion, actually three, and of course the role of the media. I've never in my entire life met people of great minds like Nigerians, but who are so unconcerned about the state of their health. Nigerians don't bother. If you go to the hospital and the doctor says this is what you have, they do not even have the mind to ask. Also, if you give me this medication, if you say I should take paracetamol 3 times a day, how does it work for me? Simple things. When last did you, if I may take a quick survey here, I'm a journalist, how many of us have been vaccinated against COVID-19? How many here? Okay, we can see that. How many of us in the last 1 year have had a medical check? As women, how many of us had pap smear in the last 3 years? Men, how many of you went for your prostate test? Oh, check. Okay. So that's the scenario. And because we are so complacent about things that affects our health, the medical practitioners, I think, take advantage of this. Because we have late presentation of what affects us, there's the possibility that wrong diagnosis will take place. Because we do not know and we do not ask questions, people get away with whatever they do with you or for you. I intend to pursue vigorously why my cousin was not treated when an onlooker helped him to the hospital in Lagos. Took him to hospital 1, he was rejected. Hospital 2, he got rejected. And on their way to the last hope, supposedly, we lost him. And so I just want to say here today, we need to wake up and speak to our rights, particularly in the health space. We are too complacent about it. We do not, if you don't ask, you don't get. We need to start asking. We need to start, if you go to an environment where it is unclean, my last minister that I worked with would say to me that you go to the hospital with a headache or a malaria, you'll be lucky if you don't come back with a cholera because of the environment there. So a lot of issues, multi-sectoral, what government is doing, how good they're doing it, what professionals are doing, how the professionals would even attend to you, the environment, all of this, I'm sure are embedded in our rights to health, quality health. I stop here for now. Thank you.
Thank you very much. So the patient's bills to rights, we find from what you're saying, is exploited by the fact that we refuse to engage, we refuse to learn and empower ourselves with the opportunities and with the simple first right to health that begins with you. It's not in the hands of anyone else, but it's in our own hands to take it. Well, if it's in our own hands to take it, then why are we so challenged with activating our rights? I'd like to ask Esquire Anthony Ojukwu, Executive Secretary of the National Human Rights Commission, to please give me your own intervention when it comes to the issue of the Patient's Bill of Rights and what do you see as a solution towards retracking this challenge? and closing the gap. Thank you. There's a microphone over there. Thank you. And I'll be holding us to 5 minutes.
Oh, thank you. It's really indeed a pleasure to be here. And once it comes to rights issues, we're always happy to discuss about our rights. Of course, you know that right to health is under Chapter 2 of the 1999 Constitution, which there are discussions about justiciability and non-justiciability of Chapter 2 rights. For us in the human rights world, we believe that even rights in Chapter 2 of the Constitution are justiciable because I give you an example. Right to life is in Chapter 4 and right to health is in Chapter 2. But if you don't have right to health, you are going to lose your right to life. Chapter 2 has right to food. They say it's not justiciable. But if you don't eat food, you are going to die. So for us, right to health is very, very critical. And that's why in 1946, the World Health Organization, of course, made it a compulsory right in its constitution. And this is also recognized in International Covenant on Economic, Social, and Cultural Rights under chapter Article 12.1, which makes it compulsory for every country to provide these healthcare services within its available resources. But that means that in every country is going to differ because it's going to be the resources available. And right here in Nigeria, of course, we have the National Health Act, we have the National Health Insurance Scheme, we have the National Primary Healthcare Development Agency, and then we have the Bill of Rights now, which was graciously given to us by the Consumer Protection Agency. Now, the Bill of Rights talks about patients' rights, patients' responsibilities, and patient and providers' responsibilities. But the issue is, how many of us know about this? So a major issue we need to deal with is to create consciousness amongst people that they even have a right. Then, what are their responsibilities? And then the responsibility of the providers, because how can you access a right which you don't know about? Now, the gap in the system now is the National Health Act provides that there is National Basic Health Care Fund, which is going to be funded 50% from the Consolidated Revenue Fund. And of course, that is devoted to the National Health Insurance Scheme. But the National Health Insurance Scheme seems to be a federal thing. The states are not really keyed into this. And more importantly too, even in the federal where they are keyed into it, people who are not working in government, are not really accessing this. So even though that infrastructure is there, that mechanism is there, how many people are accessing it? How many people are public servants? So I think this is something legislation can do. If we use legislation, the states can compulsorily, since the states are reluctant because of their independence in managing their revenue, to key into the National Health Insurance Scheme, can we use legislation, for instance, to make an insurance scheme compulsory at the state level so that they can also draw from these resources? Now, access to healthcare is critical. Access can be because of distance, for instance. If it is not close to you and you don't have transportation, I know the poverty level at the grassroots there is so enormous. So they can't access it because maybe it's not affordable. Probably the healthcare center is not even closed. So these are things we need to deal with in the new legislation.
All right,
so that people can have more access to their right to health.
Thank you very much, sir. Sir, like you said, in terms of making this intervention accessible, affordable, and in the place of its practical dimensions, actionable. Earlier on, Dr. Babatunde Irikere, when he was speaking actually, and giving us what he took up as his first charge, which was to go immediately for the Bill of Rights as touching patients and all of that. And he said, prior to, there had been no cases. Once it was done, within a month, there were 20 cases. So it was only the fact that there was no access to bringing out the patient's experience in a place of following it through to a legally applicable result and engagement. Now, he also identified the fact that you take it from the soft representation to its framework and finally to its physical location. We're looking also at what Martha said about the fact that it's not just about public sector advocacy government. We've also got to look at how we come in our partnerships. So I'd like to ask Dr. Ahmed Damfunali, our Superman when it comes to the private sector and implementation, particularly, as she said, at the ward level, getting primary health care at the ward level for communities, personalities, not just about the girl child, the woman, and because of the maternal and infant mortality rates, but the fact that engaging them in their awareness so that they become all part of that superstructure. And what would your solution-directed intervention be?
Okay, thank you very much, the Foundation, for inviting me to this program. It's obvious that one of the most important topical issues that we're dealing with currently is the universal health coverage. As we sit here now, currently in Ghana, the West African Health Community is also having a stakeholder meeting, started yesterday, and it will end tomorrow, on the same topic, universal health coverage, access to care by all and sundry. So this topic is very, very apt. Now, before I proceed to your question, let me quickly correct an impression he has just given now. The National Health Act makes provision for the Basic Health Care Provision Fund by putting 1% of the consolidated revenue of federal government into this. And as I speak with you, the money has been released and it is being executed by states, not even the National Health Insurance Scheme. Every state of the federation, whether they bring a counterpart funding or not, they have access to their own share of the Basic Healthcare Provision Fund. The Basic Healthcare Provision Fund gives healthcare free to all selected communities, at least one healthcare facility in every ward in the whole country. In FCT, we have done some registration and people are already accessing this service. As I speak with you, more than 1 million poor and vulnerable people all over the country, probably except River State, for reasons known to them, that is not currently enjoying this. So it's free and it is operational at the state level. And that is the reason why, as I speak with you, every state of the federation is encouraged to have a state social health insurance scheme. And many of them, like I said, maybe 2 or 3 is yet to have. So every state you go in Nigeria today, they have the state social health insurance scheme. Now, the formal sector, because under the health insurance scheme, you have the formal sector, you have the informal sector. The formal sector is for civil servants, just like the National Health Insurance Scheme. So the National Health Insurance Scheme enrolls federal civil servants on their formal sector, whereas any other individual that can pay, for example, 15,000 naira for a whole year can also enjoy the National Health Insurance Scheme. That's what also happened in the state. For example, I represent the FCT. We have registered all the staff of FCT and reasonable number of the area council staff. And we have a lot of individuals and companies who are not, civil servants that are enjoying this service. So that's the situation right now. There is no discrimination, even though under the equity you mentioned, every state is supposed to bring a certain percentage of equity funding to match the federal government contribution of 1%. That is a lot of issues. Many states are not responding now. But that does not mean that the rural people in those states are not enjoying this service. So I think that's the clarification for that.
Well, thank you very much, Dr. Dafulani. And like you said, no discrimination. Yeah. The equity is in there. You're working with that mobilization, as it were, this advocacy and intervention. But would we say there's a challenge in the awareness? We say there's a challenge in the profiling of whatever the milestones may be. And in going forward with that, I'm not going to get you to answer that question, just for you to, we'll get back to the final comments. But right now, let me just invite from, the WHO status, the emphasis on the area and importance of private health sector engagement to achieve universal health representation is one that is significant in its place and positioning. I think I'd like to invite, let me invite Dr. Haruna Daniel to please give me his overview in terms of your reviews from the WHO representation and architecture to where we are in the reality of this foundation and its advocacy for access and health as a human right.
Okay, thank you very much for this question. Thank you, the moderator. For me, what I've really seen about access to healthcare, particularly I work more, I operate from the state, but I go to the interiors of FCT. And actually, access is one of the issues I've seen. And I think that is where, when I saw the flying, I was very happy that he was going to be on this podium. And we really need to monitor and really see what intervention that we're putting in place, are they really working for what we're seeing? It's not just about writing the grammar. I've seen child delivery working. I've seen minor illnesses treated in distance community. I don't want to talk about the city where I live, or where we live here. I talk about the interiors, where you talk places like Kujekwa in Kuje, that will take you about 3 to 6 hours to go and come. That there are no access routes, there are no lights, but there are health workers living there, treating those residents. So for us, I think that is where we need to increase those access.
And would you say that's where you need more of the private partnerships working with?
Yes, where there should be a community-based health insurance that will improve the life of the poor of the poor, the poor of the poorer. We're not even talking about the poor, the people that can't even afford anything. There are people that can afford, maybe they pay a little bill hoping that when they sell their crops, they might be coming back to repay. But there are people that can't even afford. Those are the people that we're talking about, that we need to make sure that we protect their right, we give them this very access to health.
Well, I know that, like the advocacy here with the Francis and Mommy May, I still say Mommy May Foundation, right? Part of the challenge has really been also with some of the red tape. We're trying to bring in, for instance, their intervention from the position of private health entrepreneurship, working with the government, working in situ with the FCT. How do you take out all those roadblocks so that people in here can truly bring their own interventions to bear on the system?
For me, the government needs to play a role here, because the government has a role to play in order to allow other partners to come into this, so that we know that our government are being overwhelmed with a lot of things in their hands. So we need people, just like what we saw the foundation doing.
So maybe we need to encourage more roundtables and all of these conversations going forward. Okay then, Dr. Chenawakena, you've been Community Health Senior Malaria Technical Advisor at the WHO, kicking malaria out, but more importantly, giving access, health rights to those at the primary health care level. What is your intervention? And as a solutions personality in that sector, what would you advise? Thank you, sir.
Yeah, it's good to be here, and my profound thanks to the foundation. We are all students of productive meetings, and the utility value you take out of it is what really drives you moving forward. What has been our interventions? I'm not with WHO. I work within the US government space, just like Martha, within the malaria space. But I'll dare start by saying this. It's not the truth that you know that makes you free. it goes just beyond that. There's the truth that you know that sets you free. They are two different things. And therein comes, when we talk about health systems, how do we move towards eventually getting to that end point? And I call it the progressive universalism towards health care. It starts with you. The responsibility is yours. So what do we do? On the demand side, we need to create demand. We need to make what I call making noise around the universe. Make that noise such that it has some utility value to the space you work in. And what is the space? Your family, your kith and kin, your place of work. It's not only the government's responsibility. I think that's a misplaced mindset we need to change working out of here. There is a responsibility that everyone out of this room, if just 30% of us here could as much as live here with 30% of what we've said here today, that difference will start as we speak. Having created demand out there working with some of the partners we work out there in the malaria space, the work doesn't stop there. The barriers do exist. It could be financial, it could be the various other types of barriers, geographical barriers and all that. So one of the many things which I want to dwell a bit more on, I'll leave the facility-related issues to my co-panelists here to speak about. I already spoke about that. Breaking the geographical barrier demands that when people are not able, for whatever reason, to come to you, what do you do as a responsible parent? You go to them. So what have we done? There are a number of intervention packages that demand that you get into the community. Get to them right at their doorpost, albeit in an integrated manner. So we have interventions working towards not only creating demand, but providing services using local resources. They may not be doctors. If I dare say, yes, I may have come from that constituency, but we can't get to UHC through the doctors alone. You and I, everybody here is a stakeholder. And that's why when we talk about PHC, one of the 5, 6 cardinal principles, usually the last, it talks about intersectoral collaboration. Health, we tend to misinterpret health as for those who are within the healthcare space. The environment is there. Those who make, sorry, I like using the word making noise to rub it in. The media is there. Everyone here is some sort of health practitioner. Dare to believe that. So from there, what do we then do? We train them, we provide resources for them, and then we'll have an expectation of government. It's not Father Christmas like it used to be in our yesteryears. The stipend that they need to get, government has a responsibility. Some of our also interested parties could also have a responsibility. And how do we break into the red tapes in government? There are champions there. Try to look for those champions. The states that have adopted and taken advantage of the basic health care provision funds, the difference has been the leadership. There are states, as we speak, sourcing it. There are still some states with hands akimbo, waiting for someone to come and give them some free meal. It doesn't happen, and it's not about to happen. So there are success stories as we speak in this same Nigeria, in some localities. And for me, if you do ask me, PHC has a gatekeeping role. The challenge we've had is that that gatekeeping rule has been made redundant. And not until we get it right, the specialists can never get it right, because you're going to inundate them with too much work. Then the issues around whether we're getting it right then sets in. I probably will stop here. Thank you.
Wow. Please, let's put our hands together and appreciate Dr. Uchenna Wakeda. And yes, I'll take that connection. You were a senior technical advisor, not necessarily working with the WHO. Thank you so much. Well, he has spoken from his heart. And the truth is, it takes a real heart to heal hearts. And you know, the beauty and power of healing a broken heart is that where an institution may be broken and it takes a longer time to bring reform and transformative recovery to those institutional challenges. A broken heart just takes the compassion of a collaboration of one person, like we have heard it said. Dr. Uchenna has emphasized the fact that we are all part of an intersectoral collaboration. We are all part of a program of universalization towards holistic health care. And even as we have expectations of the government looking at the primary health care centers as gatekeeper role references, the truth is the first expectation begins where? With us. With those of you in the room today, there are very deliberate interventions that are in our hearts. And also, through our own collateral, wherever you are, you're still working, you're an entrepreneur, you're retired, being part of the value chain and institutional reform for our healthcare delivery at all levels, because as Martha Lewitt said it, it's one thing to serve the poorest of the poor, but it's a reality for everyone, however prosperous we may be, when we are challenged and impoverished through one person's health challenge. So right now we're going to be calling for questions and interventions from the floor, and then I shall return to my panel. Please, anyone very quickly. Sir, please, could you introduce yourself, your reference sphere, and your question or intervention? Thank you. Thank you very much.
Good afternoon, all.
Good afternoon, sir.
I'm Ambassador Omontayo. I'm unemployed and unemployable. All I do is just read and write. I have a number of publications on Amazing. In any case, the point I want to make is to speak on what Dr. Uchenna said, which is something that has bothered me, something I have suffered in recent times. I was living in Ikorodu. Armed robbers attacked me 2 times in a month. The second time I was so angry, I rushed at them. I attacked them in an attempt to defend myself. They wounded me on the head. I was bleeding. Then the police came, took me to the hospital. And the doctor on duty was so lackadaisical, it meant little or nothing to him. And my wife was understandably worried. I said, please, please, this is an old man. And he looked at me and said, what is happening? He said, the blood he has lost, is it up to 1 bucket? Everybody, my wife in particular, burst into tears. But later I said, look, maybe he's overworked. Thank God I got over it. But the point in this is that there is a shortage of personnel in our healthcare system. And it has resulted in a sort of mystification of medical personnel. Can we do something such as in the education part, can we create an intermediate level between doctors and nurses that will increase the personnel to the point that at no time will our primary healthcare system be short of personnel? That is one. Then 2, what happened to the domiciliary system of the old when I was growing old? Dr. Uchenna asked, if people, for whatever reason, cannot go to the hospital, why can't we go to them? So what is wrong in the domiciliary system? At that time, it was mainly for women who were pregnant, who had just given birth. But why can't it be extended? When I was researching for my book, Understanding Aging, I found that there are so many people that can't reach the primary health healthcare center, can't there be people who can go to them? Thank you.
Well, thank you very much, sir. I'm certain that we'll come to that. But please, let's put our hands together and appreciate the ambassador. Your Excellency, thank you. You may be unemployed and unemployable, but certainly the mind is not tired. And the views are fully here qualified as interventions. Yes, please. We have another microphone. Okay, over there. Thank you. Question
My
or
name
intervention?
is, I'm Dr. Semi Ola Golden. I am a private medical practitioner, and it bleeds my heart to hear this report of Madam Moji. Yes, am I right, ma'am? And then the ambassador who has just spoken now. I've listened to everyone on the eye table, and I've seen that somehow all of them know the problems that we have. But our problem has been ourselves. Let me start from the ambassador. I stand to be corrected. There is really no real shortage of personnel in health sector in Nigeria. What is there is neglect of the personnel available. If you go to many of our general hospitals, as it's been said, they are short-staffed. That's true. But go around and you find several medical practitioners wasting away in their private hospitals. And then we keep on talking about the ratio of doctors to patients. But there are doctors wasting in private hospitals. There are doctors that are wasting unemployed. There are doctors that are underemployed. It is because in our country we take health very, very lowly in our priority. And until when it happens to you or I, nobody cares to talk about it. I am, as a doctor, I am also a radio presenter on preventive health education. I present Dish of Life Extra on Vision FM 92.1 every Tuesday. And all I do, I was doing it as a community responsibility that I feel. Nobody pays me for it, and coincidentally, the radio station, they're not asking me to pay for it. But then, they are in business. They can't give me more than a very short period. What I'm trying to say here is this. How many of us are really care about the health of the neighbor? Why is it that, can I just finish? Why is it that the communities are not owing their own health care?